Okay, hopefully everybody's familiar with my rendition. This is a sagittal section of the cortical region. Here's cerebellum, there's midbrain, pons, medulla, and spinal cord, all the way down here. This structure right here is representative of the thalamus. I can label that. Okay. And we're going to start over here on the left side. Over on the right side, you have a picture or two circles. They're representative of faces that we're going to draw in, and we're going to look at the effects of a normal sympathetic tract pathway. Okay, that'll be the intact face drawing. And then if there's a problem with the sympathetic tract, the problem that occurs is called Horner syndrome. Okay, so we're going to draw Horner syndrome over here. So to get started, start over here on the left side and connect it to the faces. And the sympathetic tract itself starts in an area of the brain known as the hypothalamus. Okay, the hypothalamus. So it's below the thalamus. It's below the subthalamic nuclei. And have you guys heard of the hypothalamus in physiology yet? Maybe a little bit? No? Not yet? It's a really important part of the endocrine system. Does a lot of regulation for the endocrine system. Okay, hopefully you'll hear about it somewhere. But yeah, the hypothalamus, important in a lot of bodily function regulation. And that's where your sympathetic tract is going to start. So the sympathetic tract starts in the hypothalamus and goes down, all the way down to the levels of T1 through T3. Okay. So, neuronal cell bodies in the hypothalamus send out axons that descend through the midbrain, through the pons, through the medulla, all the way down the spinal cord to the level of T1, T2, and T3, lateral gray horn. And at the level of the lateral gray horn, T1 through T3, the sympathetic tract synapses with neuronal cell bodies here. And I'll put that these are neuronal cell bodies in the lateral gray horn. Okay, so when we did the cross sections through the brainstem, we did a couple of different cross sections, one through the medulla and the pons, and then through the midbrain. We saw this little circle that I said was a tract, and the name of it was a sympathetic tract. That's what this is. This is that tract. So nothing more than a group of axons traveling from the hypothalamus down to the level of T1 through T3 lateral gray horn. So this is your sympathetic tract. Okay, there's another player in the system, and this is going to be located here. I'm just going to represent it as a circle, and this is known as the superior cervical ganglion. Neuronal cell bodies in the lateral gray horn send out axons that synapse with the superior cervical ganglion, and these are preganglionic. Preganglionic axons coming from T1 through T3, lateral gray horn, synapse with the superior cervical ganglion. And an intact face would be that the eyes are wide open, great big, wide open eyes, and not really relevant to Horners, but I like to make everybody smile. Nice big smiley face. And we have normally dilated eyes, or normal dilation, not super constricted, not over dilated or anything like that. Okay, Horner syndrome is one of those things that you may see on the boards exam. Okay, it's pretty common. It's really important that as a physical therapist you can recognize Horner syndrome. Horner syndrome means that there's been a disruption somewhere in the sympathetic tract. And there are three things that are involved in Horner syndrome. The first thing, and all these things are coming out from the superior cervical ganglion. There's three important parts that you have to remember. Okay, the first part, axons from the superior cervical ganglion come out and are going to innervate an eyelid muscle. Does anybody remember what the name of the muscle was that opened the eye? Levator palpebrae. Good. It's the responsibility of levator palpebrae to open the eye. It's the responsibility of another smooth muscle to keep the eyelid open or fully open after levator palpebrae has done its job. Okay, that muscle is known as the superior tarsal muscle. Okay, superior tarsal muscle, smooth muscle that just maintains full eyelid opening after levator palpebrae has caused the eye to open. Another part, so that's number one. Number two is going to be innervation of the muscle responsible for pupillary dilation. Does anybody remember the name of the muscle? It's part of the iris. The dilator pupillae. Okay, that's going to be your dilator pupillae. So okay, and the dilator pupillae is the muscle that's responsible for causing dilation of the pupil. And then the third part of Horner syndrome, or sympathetic tract pathway innervation, is going to be to facial sweat glands. Okay, facial sweat glands are going to be part of the sympathetic tract pathway. So it's going to be ipsilateral. So for example, if this is the left sympathetic tract pathway, it's going to work with the left side. And the same for this. So if the sympathetic tract pathway is disrupted anywhere, you're going to have a classic presentation. The first is the lack of the function of superior tarsal muscle. The levator palpebrae has opened the eye, but the superior tarsal keeps it open, so you're going to see a drooping eyelid. I'll represent that here, and it's going to be ipsilateral. It's going to be a drooping eyelid on the left side. Okay, this is left. So if I disrupted the left sympathetic tract, I'd see left eyelid drooping. Okay, and that's due to lack of innervation in the superior tarsal muscle. So I'm going to say eyelid droop. Does anyone know the medical term for a drooping eyelid? It has a very specific name, something you should associate with Horner syndrome in combination with these other things, called ptosis. Ptosis, P-T-O-S-I-S. A drooping eyelid, also known as ptosis. P-T-O-S-I-S. Okay, so it's the left side's affected, so the right side looks just like a normal eye, fully opened eyelid. You have a question, Hannah?
Sympathetic tract, what?
Disruption. Yeah, so I'm just trying to show you that it's ipsilateral. So if the left sympathetic tract is disrupted, you're going to see symptoms on the left side of the person's face. Any other questions? Did you see that? Okay, and the right side is going to look like normal, so that full eyelid opening, but on the left you're going to see something called ptosis. That means the eyelid isn't fully opened. If the dilator pupillae muscle is affected on the left side, what do you think as far as pupil size you're going to see? Yeah, constrictor, right? So it's going to be constricted, okay? And on the right side it's going to look normal, just like the other side. Okay. Now this pupillary constriction also has a name. So I'll put pupillary constriction. And the name for pupillary constriction, or the name that you should associate with this, is called meiosis. And that's M-I-O-S-O-S. No, M-I-O-S-I-S. Meiosis. Okay, meiosis is nothing more than the medical term for a constricted pupil. Okay, and that pupil is constricted because the dilator pupillae is not innervated. Okay, and this has nothing to do with Horner syndrome, but the person's still smiling. Now, if you affected the facial sweat glands only on the left side, the patient's will present with a flushed red face on half of their face, on the affected half. Okay, so it's going to be flushed and red because there isn't any sweating to cause cooling off. Okay, the person's not going to be able to sweat, so we're going to have the whole half of their face is going to be flushed and red. Okay, and this has a name. This flushed face is due to something called anhidrosis. A-N-H-I-D-R-O-U-S. Anhidrosis. Anhidrosis means lack of facial sweating. Three things in combination. You have ptosis, meiosis, and anhidrosis. I think Dr. Friend has introduced me to her cure of ptosis, meiosis, anhidrosis. Okay, whatever it takes to remember it. Those three things in combination are Horner syndrome. Okay, Horner syndrome, if the person doesn't have a diagnosis of Horner syndrome previously, that indicates a disruption to the sympathetic tract, which is part of your central nervous system. Refer. Send somebody, let somebody else know. Question?
Will they all present together?
Yes, they have to present together. Meiosis, ptosis, and anhidrosis all present together. So that person has one side of the face might be a little bit damp, the other side's going to be dry and red because I can't cool off. Okay, definitely lowering of the eyelid, ptosis, and meiosis is that constricted pupil. It doesn't change, no matter what. Okay. Questions about that? It's kind of an important concept. I'm sure you're going to see it again, no doubt. So, that sympathetic tract pathway, there's no other questions. We'll move on to cranial nerves and blood supply. And now this is where we're going to start putting everything together. Oh. So going way back, I think it was the second class, we talked about the blood supply, and toward the end of this semester, about a little bit after midway, we talked about the cranial nerves and their positions. So what I'd like to do is start out by drawing the cranial nerves in. Again, here's my midbrain, cerebral aqueduct. This is a nice landmark. Here's midbrain, and here's your pons, here's your medulla with spinal cord, and here's your cerebellum in the back. Okay, so you're looking at this like you're looking at me. This is front, this is ventral, back is dorsal. Okay, and we talked before about the special sulcus. This is going to be your pre-olivary sulcus. And just for the sake of crowding or lack of crowding, I'm going to draw all the cranial nerves on one side. What was the name of that cranial nerve that came out of the pre-olivary sulcus? Does anybody remember? It's in the medulla? Hypoglossal, great. Okay, so that's gonna, let's go ahead and put in the hypoglossal here. Okay, this is cranial nerve 12. Okay, cranial nerve 12 arises out of the pre-olivary sulcus. Cranial nerve 11 is going to be down here, coming from the ventral great horn of C1 through C5, so we're not going to include that up here, but there's 12 counting upward now, so 12 going down to 11, going back to 10. Cranial nerve number 10 is about right here. Counting backward. Okay, and cranial nerve number 9 is there also. So cranial nerve 10 is vagus, cranial nerve 9, glossopharyngeal. Okay, and just relative positions of where they reside on the end of the brain stem. And then thinking back to the next in line, you're going to have cranial nerve numbers 8, and then 7, and then most medial is going to be 6. Okay, so vestibulocochlear, cranial nerve 8. We've got facial, cranial nerve 7. Whoops. And then you have abducens, cranial nerve 6. So just a review from way back when we did these cranial nerves. Somebody who's not typically involved. So here's going to be coming out of the lateral side of the pons. It's going to be the big one, cranial nerve 5, trigeminal. about cranial nerve number 4, arriving to the ventral surface from the dorsal side. It's the only one that comes out, so it comes out the back and arrives in the front. Okay, that's your trochlear. And then the last one that we've talked about a bunch is going to be up here at the level of the superior colliculus. That's going to be cranial nerve 3, ocular motor. Pretty much just a quick review. Going backward, 12 out of the prealveolar sulcus, 11 down here, not going to be in this drawing. Then with counting up, we go 10, or counting down, go 10, and then 9 in the medulla. And then in the pons proper, we have our 4 cranial nerve 8, 7, 6, and 5. And then above the pons, there's 2 more plus 2 that aren't in the brainstem. Cranial nerve 4 is here coming out of the midbrain, and ocular motor, which is cranial nerve 3, also coming out of the midbrain, just a little bit higher. Overall, that's where we are. Now, thinking way back to when we did the blood supply to the brain, second day of class, we had these 2 arteries coming from below that came together to form one main artery. At the base of the pontomedullary junction. Yeah. This way?
Yeah.
There you go. Does anybody remember what the name of those arteries were? Yeah, those are vertebral arteries. Left and right vertebral. Okay. You had to guess which artery supplies the middle of the medulla and cranial nerve 12 with blood. Vertebral. There you go. So here's going to be the territory. It's going to be most medial, okay, all the way here. This is going to be your vertebral artery territory. It's going to be when you think about vertebral artery territory as far as the medulla is concerned, you're thinking medial medulla. And medial medulla and the cranial nerve that could be affected is going to be cranial nerve number 12. Overlays nicely. Okay. Going up, think about at the level of the pontomedullary junction, the 2 vertebral arteries join together as one, form one main artery that ascends through the pons just above the level of the 3rd cranial nerve. We have, which artery was that? Basilar. Memories of the first half. Okay, and then coming off the basilar, if you remember, there were these little arteries that supply the left and right half of the pons with blood. Teeny tiny little guys. Pontine, good. And those are your pontine arteries. Okay, at the top, just above the level of the 3rd cranial nerve, basilar artery splits off into 2 that go back. And that is, which arteries are those? Left and right. Anybody remember what these arteries here? Off the top of the basilar splits off into PCA, left and right PCA, posterior cerebral arteries. coming off the vertebral artery, back down here, we're thinking about arteries that supply the posterior inferior surface of the cerebellum. Okay, you're going to come off your vertebral and supply the posterior inferior surface of the cerebellum with blood. Which artery was that? Pica. So that's your left and right pica. Think about the position of where pica's supplying blood to, and you think about the position of cranial nerve 9 and 10, you can see that they fall nicely into pica's territory. So, pica is the artery that's responsible for supplying the lateral part of the medulla with blood. And specifically, if cranial nerves 9 and 10 are involved, you're thinking pica was disrupted, just based on position. Okay. There's a couple of, so for cranial nerve, and we'll talk about two different things, but let's just think about disruption here, this is the left side. If there was a disruption of the pontine artery, which is most medial here, in the pons, its territory is going to be here. Okay, and the pontine artery on that side, on either side, is responsible for supplying blood to cranial nerve number 6. So if cranial nerve number 6 has a problem, and you're thinking pontine artery might be involved. And coming off the pontine artery, there was another artery, off the basilar artery, there's another artery that we talked about that comes off the basilar and supplies the anterior inferior surface of the cerebellum with blood. And this one, does anybody remember which one that was? Ica. Pica's sister. Here's Ica. Okay, and Ica's territory, as you can see from the picture, is going to be the lateral pons. Okay, and if Ica is affected, you might also see cranial nerve 7 and 8 being affected. Moving on up, the other one we're going to talk about as being important is going to be oculomotor. Okay, the arteries that are responsible for supplying the midbrain with blood that may affect oculomotor activity are going to be both the PCA and the basilar, because they're going to both be medial here. PCA and the basilar are going to be responsible for supplying the medial midbrain with blood. Okay, so what we went over at the very beginning of the semester is the blood supply, the vertebral basilar blood supply to the brainstem. And if you overlay that blood supply on top of pictures of the cranial nerves, yes, Hannah?
For the PCA and the basilar artery, the circle around cranial nerve 3, is that just the PCA territory, or would it be both PCA and the basilar artery?
PCA and basilar.
Okay.
Yep. I tried to do two different colors. They might not be discernible on the screen. Yep, both PCA and basilar are responsible for what's called a medial midbrain syndrome. Right? We're going to get there. We'll see that as we go. Other questions? Any questions about this? So when you overlay the blood supply on where you know those cranial nerves should be, it's pretty easy to see who does what. Yes, Hannah. I'm sorry, can you say that again?
What were the Fontaine arteries?
Cranial nerve number 6. Cranial nerve number 6. There's that. So we're going to talk about left and right or sided medial pontine syndrome, but there's also bilateral. And a bilateral pontine syndrome is something very special. It's called locked-in syndrome. We'll talk about that when we get there. But that's going to be basal, not just pontine. Yes, very.
No, but PCA is posterior cerebral, posterior communicating. I can't remember.
Posterior cerebral. It's the big one. It supplies your occipital lobe with blood. Posterior communicating is just part of the circle of Willis, connecting front and back. Any other questions? Anything that isn't clear as far as what we're seeing? So right now, I'm just showing you the big picture, how the blood supply overlies with the cranial nerves, because it helps me remember which artery is involved. Jared?
Do you associate a blood supply with the cranial nerve 4?
No blood supply. So there's going to be no patient signs and symptoms that are discernible through a blood stem stroke. Okay, that's with a brainstem stroke. This is all about brainstem vascular syndromes. There's only a few that we're going to look at. Yes?
You said locked-in syndrome is basically.
Locked-in syndrome is basilar. And that's something, I'm not going to draw it, but we're going to talk about it a little bit when we get to the medial pons. Any other questions? Everybody see where we are? Okay. So it helps me to try and visualize, if I know my blood supply really well and I know where my cranial nerves are and I know what the cranial nerve function is, I can implicate an artery that's been affected in a brainstem stroke or brainstem vascular syndrome. Questions? No more questions? All right, let's move on then. The next one we're going to look at, we're going to start with medial medullary syndrome. Okay, and medial medullary syndrome is going to be here, medial, affecting cranial nerve number 12. Remember, the nucleus for cranial nerve number 12 is all the way throughout. So, go here. And we looked at this when we did cross-section through the brainstem previously. So medial medullary syndrome, if I had to talk about an artery that was disrupted in medial medullary, which one was that going to be again? Does anyone remember? Vertebral, yeah. So this is going to be disruption of vertebral artery. Okay, and I'm just going to go ahead so we can label this. Okay, this is a cross-section through the medulla. Thinking about labeling it, as always, this is going to be ventral. I know that because I know that the cranial nerves exit ventrally. And then this is going to be dorsal. Now, all we have to do is go through and label the parts like we've done previously for the midbrain, or for the brainstem's overview. This is the cranial nerve that's involved. So in the medial medulla, it's going to be cranial nerve number 12. All the parts. And if I talked about this tract, that's always going to be most ventral. Okay, there's going to be a pair of tracts here. Which tract is this that's most ventral? Great. Yeah, this is your corticospinal tract. And if this is in the rostral medulla, has the corticospinal tract decussated yet? Nope, it hasn't. All right, So that's an important piece of information. Okay. Moving on over here. This is going to be a nucleus that's associated with the cerebellum. It sends out climbing fibers to the cerebellum. Which one is that? Inferior olivary. Not superior. Right. Superior is associated with auditory system. This is going to be my inferior olivary nucleus. Okay, so far so good. Let's move inside a little bit and think about this guy. I'll make it blue. This is going to be, does anybody know which tract this is? Perfect. Associated with vibration, proprioception, and fine touch. And if this is the rostral medulla, has this DCML pathway crossed over yet? Nope. Coming from down, it's contralateral still. It's contralateral. It's above where it's decusated. So here, this is your medial lemniscus. Okay, second part of the DCML pathway. On top of the medial lemniscus, this is that tract that we talked about the other day that connects all the cranial nerves that are involved in extraocular eye motions with the vestibular pathway, with the vestibular nucleus. This is your medial longitudinal fasciculus. Good. Awesome. And this little guy, we talked about this tract today. This is involved. Disruption of this tract produces Horner syndrome. Which one is that? Yep, there's your sympathetic tract. Perfect. We also have kind of a little C-shaped thing here on the side. Does anybody know this one? Yeah, spinal nucleus of trigeminal. Okay, your spinal nucleus of trigeminal. Involved in receiving sensory information from the head and face area. We talked about pink, I guess. We talked about this nucleus. This nucleus is associated with cranial nerves 9 and 10. It doesn't really know, it's or motor function associated with cranial nerves 9 and 10. It doesn't really know who it belongs to. Which one is that one? That is your nucleus ambiguus. Nucleus ambiguous. Then we have, what color to use? Let's go ahead and, what am I not done? Dark green. Okay, this guy hangs out, it's always close by with the sympathetic tract. It's involved in transmission of pain, crude touch, and temperature from extremities. Yep, this is your STT, spinothalamic tract. Where am I? Oh, there it is. And then the only one we haven't talked about is way over here. And this is that most inferior conduit from the brain stem into the cerebellum. This is your inferior cerebellar peduncle. Okay, a little little bit of review. It'll be helpful for the exam. Now, one thing that I didn't draw in there yet is the position of the vertebral arteries. So if I told you that the vertebral arteries are located here and here, like I showed previously in that pre-olivary sulcus, these are your vertebral arteries. Okay, that's one thing to know. The other thing to consider is the middle. Okay, so we're thinking about left, so we're worried about this side. So here's your midline. And the territory, the exact territory for the vertebral artery is going to be here. Okay, so everything in the middle here, everything in this medial region is going to be affected. Okay, so everything on that left side, the left vertebral artery is affected, disrupted. Everything here in the shaded region is going to be affected. Flash. So, if cranial nerve number 12, which we've labeled, is disrupted, how's the patient going to present? Yeah, your tongue is going to deviate to the left, right? It's going to point to the lesion, the side of the lesion. Okay, if your medial longitudinal fasciculus is affected, I don't know if did we talk about what kinds of symptoms you get if your MLF was affected? What do you think? Something's wrong with your eyes, right? So you're going to get something. So your eyes aren't moving together. If your eyes are moving together, that's called a conjugate gaze. So if your MLF is disrupted, you're going to get a dysconjugate gaze. D-Y-S-C-O. Okay, that's a dysconjugate gaze. That means one eye is pointing in one direction, the other eye is pointing in the other direction. Okay, so if MLF is affected, you're going to get, the patient's going to present with a dysconjugate gaze. Gaze, G-A-Z-E. Yeah. That's a fancy word. I was working in an inpatient hospital in Chattanooga. Great place to work, by the way. I had an OT friend. She was a CODA, or she is a CODA. She's still a CODA. And we had the same patient, working with the same patient. And she was looking at me. We're talking about this person, and she says, "Oh, he has atrophoria eyes." And it's relatively new PT, and I hadn't heard of that term before, atrophoria eyes. And so I said, "Can you tell me what that means? I've never heard of that." And she said, "Yeah, one eye's looking at you, the other eye's looking for you." True. But OTs are fun to work with. So you get dysconjugate gaze. Now, if the medial lemniscus is affected, what happens? Well, how's the patient going to present? They're going to use fine touch, vibration, and proprioception sense, right? And if the cortical spinal tract is disrupted, they lose movement, right? Motor function on one side. Okay, so I've gone through and labeled all this stuff for you. After we're done these drawings, on the slides, I've left some blanks. And your job is to fill out ipsilateral or contralateral as far as the lesions are concerned. Okay, we'll go through that after we do the drawings. But does everybody see what happens? So if you can draw this cross section and identify things, know vertebral artery and where it hits, you can predict patient signs and symptoms for something known as medial medullary syndrome. Okay, patient's going to present with this constellation of signs and symptoms. You know it's in the medulla because cranial nerve number 12 is affected. Questions? Okay, let's move on to the next one. This is going to be lateral medullary syndrome. Lateral medullary syndrome is probably going to be one of your more common. It's so common it has a name, and it's called Wallenberg's syndrome. Okay, so this is the same cross-section that we just looked at through the medulla. So all we're going to do is go through and label things again, just like we did before. So this is going to be your inferior cerebellar peduncle. Now here's your 12th cranial nerve. Try to use the same colors. Okay, here's your nucleus ambiguus. Here. Here's your spinal nucleus or trigeminal. It was blue. Your sympathetic tract hanging around with the spinal thalamic tract is just black. Spinal thalamic tract I use is green. Here's your inferior olivary nucleus. And your corticospinal tract. And the last one here in the middle, your medial longitudinal fasciculus. I'm sorry, your medial lemniscus, and on top of that is your medial longitudinal fasciculus. Okay, so no changes from the last diagram, exactly the same. All I did is I tried to keep the same colors to make things a little bit consistent, or try to make it consistent anyway. Questions? Okay, let's take a 10-minute break.